Hi everybody, my name is Bill Weintraub. I'm the John H. Ammon Chair of Cardiology and Director of the Cardiology section at Christiana Care Health System in Delaware. I'm also Professor of Medicine at Thomas Jefferson University and Director of the Christiana Care Center for Outcomes Research at Christiana. In the center, we work on a very important topic for much of our research, and that's comparative effectiveness. And this afternoon, we're going to discuss this very important topic, a topic that you may have read about in the media, but unless you work in this area, it can be somewhat obscure and hard to understand. And yet it's very important because in comparative effectiveness, we study some of the most important healthcare issues in our society. So we're going to discuss this this afternoon. We're going to have a series of brief presentations and then a roundtable discussion. Let me begin by introducing my colleagues. Dr. Daniel Elliott from the Department of Medicine at Christiana, Dr. Claudine Jerkovitz from the Christiana Care Center for Outcomes Research, Dr. Deborah Ehrenthal from the Department of Women's Health at Christiana, and Dr. Hisham Sharif from the Department of Surgery at Christiana. So you see our departments here are well represented in this, and we're going to hear about research in these several different areas. Now let me begin by talking about comparative effectiveness a little bit and what this is all about. So what do we do in comparative effectiveness studies? These are studies in which we conduct and synthesize research comparing the benefits and harms of various interventions and strategies, therapeutic and diagnostic, for treating and managing some of our most important healthcare conditions. And I want to emphasize that this is research in a real-world setting as opposed to the narrower world of efficacy-focused randomized trials, which are very often aimed at registering new products with the FDA. This is more about healthcare delivery and taking care of our fellow citizens. Now, we also seek to improve health by disseminating our results. So it's not enough to study, we need to apply what we learn. And in comparative effectiveness research, we also study the various methods that we use to implement our research and study the best way of delivering medical care. Now, what are the things we study? The Institute of Medicine of the National Academy of Sciences was charged by Congress with coming up with the top 100 questions that we should address in comparative effectiveness research. And these are displayed before you presently. Now, about half of these are actually related to healthcare delivery issues. And much of our research at Christiana in comparative effectiveness at CCOR is related to studying healthcare delivery. So what do we do at the Christiana Care Center for Outcomes Research? We provide epidemiologic and analytic resources to improve our understanding and to study our outcomes. We provide design, data handling, and analytic resources to assist investigators throughout the healthcare system and also to help our collaborators in many institutions beyond our own healthcare system. We develop clinical, epidemiologic, and translational and outcomes projects, both for internal use in improving our care here at home at Christiana, for industry-funded research, and also for peer-reviewed research, much of it sponsored by the National Institutes of Health. We have particular areas of expertise at CCOR in protocol conceptualization and development, biostatistics and epidemiology, informatics, and data management. These are the skill sets and the areas of expertise that investigators are always looking for to be able to conduct their research. Now let's go on to discuss some examples of the kinds of research we do. So let me start by turning things over to my colleague, Dr. Daniel Elliott.
Thank you, Bill. As Bill mentioned, the Institute of Medicine priority list had a large focus on healthcare delivery systems, the evaluation of healthcare delivery systems and interventions. And I'm just going to give you some very brief examples of some of the work that we've done here that I've led with my colleagues at CCOR and throughout Christiana. And the first of those is a project that we've done that's investigated hospitalist efficiency and its relation to clinical outcomes. And our fundamental question that we're asking is, can we identify a patient census or a patient volume that maximizes the efficiency and quality of the inpatient care that's delivered by hospitalists? And the way we've designed this study is as a retrospective cohort study where we're matching inpatient billing data from a large private hospitalist service with the administrative data that's captured within Christiana's data warehouse. And we're looking at the evaluation over a 3-year period where we're going to evaluate daily patient census and workload of physicians and its relation to patient-centered outcomes, length of stay, cost, and quality metrics. And we're just beginning this evaluation presently, but we'll be doing the evaluation with over 25,000 hospitalizations. The second project is in an ambulatory setting, and we're looking to see if a report card, a diabetes report card, with standard diabetes quality measures that are derived from the electronic health record, if that's given to both providers and patients at routine office visit, can improve the quality of diabetes care. And this was a pre-post study that we completed last year, and our primary outcome was the impact of this diabetes report card on therapeutic intensification. And that just meant that for every process metric or quality metric that was out of date or out of control for a patient, the physician would identify, would either order a lab, refer to another physician, or add or intensify medication therapy. And it's just an example of the report card. It was printed out of the electronic health record and given to the patient and the provider. And this just shows you very briefly that what we found was that we were able to identify a statistically significant increase in the proportion of our patients who had 4 or 5 of the quality metrics that we measured, either in control or intensified in the post period, in the intervention period. So that indicates that there was some movement of patient-centered decision making and provider action as a result of the diabetes report card in our practice setting. The third main area that we've been working in is emergency department use among a high-risk urban population. And our fundamental question was, does notifying primary care physicians that their patients have been in the emergency department actually improve subsequent utilization patterns? And this has been a multidisciplinary project with both residents and faculty here at Christiana Care. And what we found was a very modest increase in the proportion of patients who actually returned for an office visit at our primary care practice following an emergency department visit. Now, we weren't quite satisfied with the degree of impact that we were able to see here, so we're now beginning a project where we're testing whether a nurse navigator structured phone call can actually improve subsequent utilization following that same initial emergency department visit. So it's building on our previous work. This time, however, we're going to use a stronger design, a prospective randomized cohort, where we have the structured phone call compared to usual care in our practice. And again, our outcomes are going to be follow-up both in our office and this time subsequent utilization of both the emergency department and hospitalizations.
Thanks, Dan. That was really terrific. Let me ask you a question, in particular about the diabetes report card project. You noted in that study that you're using a pre-post design. Can you tell us what you mean by that? How did you choose that design? What were the alternatives? Why was this the best one?
Well, the pre-post design essentially assesses the change in outcomes from the period before we applied the intervention to the period after we applied the intervention. Now, the pre-post design is notoriously a weak design in that it's subject to bias by confounders. Now, we do the best that we can to measure patient characteristics and other things that confound the data, but unfortunately you're subject to things that you can't measure, so unmeasured confounding by patient characteristics or other things that may have happened in your process. In your office, for instance, we were worried about things that might have changed. Now, a stronger design, of course, is what we're trying to employ in the second part of that project, where we're actually using a randomized design to look at this intervention, and that helps us balance these both measured and unmeasured confounders as we move forward.
Well, thanks, Dan. You mentioned a very important word, and that is confounders. I'm not going to discuss that now, but I'm going to come back to it, so everyone should be prepared for some interesting things to say about that. And now I'd like to ask my colleague, Dr. Claudine Jerkovitz, to discuss some of her research.
Thank you, Bill. This is a perfect timing because I'm also going to talk about confounding. In this study, we compare several statistical methods and analytical tools to analyze cost-effectiveness data from registry. And typically, it's important to know that cost-effectiveness analyses are done from randomized clinical trial. So registry data really raised several issues that I'm going to discuss now. This study was funded by Sanofi that also funded the RECORD AF registry. So RECORD stands for Registry of Rhythmic Disorder. And this was a registry that was done in 21 countries, a very large registry from 532 clinical sites, and enrolled 5,600 eligible patients during 1 year. The goal of the economic analysis was to compare cost of rhythm versus rate control treatments and to perform cost-effectiveness analysis. We studied the cost, we looked at the cost of hospitalization, atrial fibrillation and non-atrial fibrillation medications, procedures, bleeding, and also, of course, the total costs. Again, we compare the cost and cost-effectiveness analysis of rhythm versus rate control. And comparison of treatment in non-randomized really raised, as I said, major confounding, one of the most important issue being treatment selection bias. So some of the techniques that we can use to control for confounding and to decrease the effect of selection bias is to adjust for potential confounders. And that's something that we do in the model. However, this is not very good for the bias, the indication bias. It's to adjust for propensity score, and a propensity score is a probability of the physician to treat a patient by one treatment or another. And this is very important because the physician treats the patient according to his assessment of the patient and according to other guidelines. These patients are not randomized in one group or another group. We can also match by propensity score, which means that each probability which is given by the propensity score is assigned to a patient, and patients are matched according to their probability of being in a treatment group. And we can also do what we call stable inverse probability weighting, where we take the inverse of the propensity score and stabilize it with the frequency of patients in each treatment group. So these are the clinical and demographic characteristics of our population. The population, we had approximately the same number of patients. However, this is not, and it's very obvious here, this is not a randomized trial. The two treatment groups are not well balanced. Patients are much older in the rate strategic group, and they also have more comorbidities such as history of MI, history of stroke, history of diabetes, and most importantly, there is a much higher frequency of patients with heart failure and with severe heart failure among the rate strategy treatment group. So this is a cost-effectiveness analysis, and what we did, we did an analysis in 1 year and a lifetime cost analysis. We separated into no adjustment, stabilized, inverse probability weighting, and matched adjustment. So the patients, there were 4,500 patients in the no adjustment group technique, and less patients in the inverse probability weighting techniques, 3,325, and even less patients in the match analysis. And that's one of the major issues of the match analysis, is that some patients do not match, so we have less patients in the analysis. And finally, to summarize this data, we found that patients the group who was analyzed without adjustment the rhythm was dominant compared to rate, meaning that it was less costly and more effective. Whereas when we did the stabilized inverse probability weighting, we found that the group was cost effective, and that it was approximately $1,100 for 1 year gain in quality adjusted life years. And it was a little less for the matched analysis. However, all the costs for 1 year gain in QALYs were less than 30,000 for rhythm control. So in conclusion, these methods resulted in differences in difference in costs, in difference in quality-adjusted life years, in difference is incremental cost-effectiveness ratios. The differences were not large enough, however, to alter conclusions about treatment decision-making, and it's very important to analyze with all the methods and to conduct sensitivity analysis.
Thank you, Claudine. Well, that was a tremendous amount of information, and I don't expect everybody listening to this to understand all the methodologic details, but I want to take you up to the purpose of all of this in the first place, and that is one of the things that's said about cost-effectiveness analysis. It can help us understand the value of one form of therapy versus another, but very often there isn't enough information and the data are not reliable enough in a cost-effectiveness analysis, and you can see how complicated this is technically. So very often we say that it's not strong enough to make policy decisions. Is that your feeling as well?
Yes, I think we need to have a mix of randomized clinical trials and a non-randomized study for comparative effectiveness analysis. Comparative effectiveness is sufficient. However, it's important to have a mix of these trials, of these studies.
Yeah, so I was talking really also about the purpose of cost-effectiveness analysis to help us find value. Okay, let's move on and hear from Dr. Deborah Ehrenthal.
Thank you so much, Bill. So I'm going to talk with you about some work that's being done in the Department of Obstetrics and Gynecology. And I'm going to skip this slide and move on to the first project, which is looking at outcomes for robotic versus abdominal hysterectomy. And I think a lot of the background that Dr. Jurkovits talked about is really pertinent to this study. Hysterectomy is the second most frequently performed major surgical procedure in reproductive age women. And recently, the Da Vinci robot has been introduced as a novel, less invasive approach to perform this surgery. But it really hasn't been tested head-to-head against traditional approaches, for example, abdominal hysterectomy. So we were interested in asking the questions, even though a robotic surgery provides a less invasive approach, does it reduce complications after hysterectomy, and is it cost-effective to use? So we're going to be doing this study at our institution, looking at the experience we've had over the past few years with robotics. So it's a retrospective cohort study of robotic versus abdominal hysterectomy for benign disease. But just like in the record registry we heard about, patients are allocated to either robotic versus abdominal hysterectomy by their physician. So they're not randomized, and they appear in each of these groups based on physician and patient preference. Which creates very different cohorts. Now, I can't show you the data for that because it's ongoing, but if we were to look at the characteristics of the groups, just as in the prior project that you heard about, they will look very different, and these differences will impact the outcomes that we see. So we're going to be completing this study by choosing cases that all of the cases that we have in our registry who've had robotic surgery, and then we're going to be matching them to cases who've had abdominal hysterectomy that are going to be similar by age and other factors that we think are going to be impacting outcomes. And we'll be using that to look at the outcomes of complications and also cost. The second study is a very different study, but again, it's using a non-randomized design for an intervention that really can't be randomized. And this is using a design very similar to Dan's that he talked about with the diabetes report card. This is a study looking at the implementation of delivery guidelines at a large hospital system and looking to see how it impacts outcomes for neonates. This is being implemented nationally. It's been implemented at sites before, and it's really being done because of consistent studies that show that early delivery, or babies delivered less than 39 weeks, are more likely to have adverse outcomes than babies who are delivered 39 or more weeks. And the question we asked with this study is, does elimination of elective delivery before 39 weeks lead to these improved neonatal outcomes that we're expecting? So this is a pre-post design, or a before and after study, as Dr. Elliott talked about, looking at the outcomes at the institution before institution of the guidelines and after. Again, we're going to need to adjust or control or take into account the differences in the populations before and after the guidelines, and we can do that through adjustment, as Dr. Jurkovich talked about, and look to see how that impacts outcomes. And I can give you some results from this study. We found that enforcement of this guideline really did change practice in the community, and we saw an increase in delivery at 39 or more weeks. And we did see associated with that a small reduction in the rate of NICU admission. There was a suggestion, though, that there is some increase in some adverse outcomes that might be predicted biologically but haven't really been evaluated yet. And we're seeing an increase in, a small increase in babies born in macrosomic or with a birth weight greater than 4,000 grams, and potentially a small increase in stillbirth at term. So using this approach, before and after design, using our institutional data, we're able to look at the impact of policy and see that it was associated with changes in practice, but potentially some adverse outcomes downstream.
Thanks, Deb. That was terrific. Well, all three of the panelists so far have talked about non-randomized designs in the studies they're doing and the issue of confounding. What is confounding, Deb? Why is it so important? Why is it something we have to deal with it in our studies? And how can we deal with it?
That's a great question. You know, confounding is the existence of a factor that's associated both with your exposure, so in the case of the robotic surgery, the choice of surgery, and the outcome. And if you're unaware of it, it can lead you to make inferences that your exposure is associated with that outcome. Now, when we do randomized studies, we eliminate this confounding because we're randomizing people. So even if we're not aware that there's something out there that is affecting those results, we wash it out by randomization. When we do these non-randomized studies, we don't have that luxury. And so what we need to do is we need to rely on clinical judgment and prior work to identify those confounders and account for them in our statistical methods to try to eliminate their effect on that association.
Can we eliminate confounding with statistical approaches?
That's if only we could. And I think there's always residual confounding that we need to be concerned about, which is why we go to great lengths to look at different ways to adjust for these confoundings. We talked about propensity matching, we talked about adjustment, we talked about inverse matching. And that's also why we want to compare what we find to studies with other designs to see if the findings are consistent. So there's always potential residual confounding that we need to be concerned about.
All right, so this is one of the really important things to understand, because when we do comparative effectiveness studies, randomized trials will eliminate confounding, or sometimes called treatment selection bias, because it allows random assignment and will balance both the things we measure and the things we don't measure. You can't do that in observational studies. In observational studies, you can correct for the things you measure, but you can't correct for the things you don't measure or can't measure. And so there's always the problem in non-randomized trials of residual confounding or residual treatment selection bias. And that's why, as Dr. Jurkovich said, we need a mix of randomized and non-randomized studies. Now, let's hear from the Department of Surgery and Dr. Hisham Sharif.
Thanks very much, Bill. As my colleagues introduced, one of the main goals of comparative efficiency research is to identify the decisions that will give us better outcomes, better clinical outcomes. In other words, we want to increase the quality and safety and efficiency of healthcare. And based on the clinician's decisions, outcomes can be resource intensive, they can be unsafe, or they can provide less than optimal quality healthcare. So we decided to see if we can develop some way of predicting the outcomes based on the clinical decisions of not only physicians but other clinicians as well, and to see if we can factor in all the other parameters that we may not be readily aware of. So working with the Department of Cardiology, we decided to put together a computer-based decision support system to try to predict the outcome of the patient's situation, clinical situation, based on the information that we have, and to determine if that outcome would be severe enough to warrant one action or the other. So we designed two studies. The first was from the acute coronary syndrome, acute myocardial infarction population who present with disturbed or decreased level of consciousness after their initial resuscitation. And our goal was to see if coronary revascularization, typically in the cath lab, would be of value in these patients given the likelihood of their neurologic recovery. So we looked at 99 patients from our registry at the Christiana, and we were able to identify several factors, including age and the time they were unresponsive during the resuscitation efforts. And we built a computer program to try to simulate the clinical decision-making process involved in that. And we compared our findings from the clinical arena and the findings through the computer, and they were pretty consistent, which prompted us to conduct the second study with the aim of predicting the likelihood or probability of the patient being in acute decompensated heart failure when they present in the emergency room with symptoms suggestive of this situation. So we looked at, first we had the first phase of the study was 20 patients, which we developed hypothetical parameters just to see if the computer program would function appropriately, and it did. So we took it to the next patient population. We looked at 100 cases of ER admissions for symptoms that were suggestive of acute heart failure, namely shortness of breath. And we broke them into two almost equally groups of documented heart failure versus other diagnoses. And we ran the program using several parameters that we agreed on with our working group. And we had a very impressive accuracy rate. The program not only was successful in predicting the correct diagnosis based on the clinical parameters of the patient, but also recommended the correct course of action, whether we should admit that patient or discharge them or put them in an observation unit. And this is a brief graphic representation of our results. The top graph is our first result. The accuracy rate was about 85%, and the two bottom ones represent the accuracy rate on the left for the target diagnosis, which is acute heart failure. It reached 98%, and the right graph breaks down the accuracy rate in the other diagnosis. So in conclusion, we can say that there are many methods to adjust for the variables or the confounders in the clinical data that we are faced with, whether it's statistical methods or computer-based methods, which have performed very satisfactorily in this particular study.
Well, that's terrific, thanks. So, Hisham, would you say then that we can say that computerized decision support can help us improve patient outcomes?
Absolutely.
So this is another very important lesson, because I think that we who grew up in medicine a long time ago were used to the idea of that we would become master clinicians someday and could master our fields. But I think today we've learned that that's not realistic. And so the computer doesn't really do its thinking for us, but the computer can help us marshal our facts and help us develop algorithms to improve care. And that's the way we should think about computerized decision support. It's not making cookbook medicine, but rather what we're really doing is helping the clinician think about medicine in a better way. Is that fair to say?
Yeah, that's very correct. And the other advantage of computer-based decision supports is that it can include the many factors that are not in front stage or center stage to the clinician. And it can correlate without any bias all the influences of these factors.
So you see here the different kinds of research we're also talking about. Dr. Jurkovitz was talking about not efficacy, not narrow efficacy, but really effectiveness of two different treatment strategies. Dr. Sharif, on the other hand, was talking about implementation research, where we're going out and doing something in the field to really make things happen. Two different kinds of research that are yet beyond efficacy. So now let me ask a series of questions to the panel. And the first is about the nature of comparative effectiveness and what this adds to our entire field of research. Now, we've been doing randomized trials for years. Some was conducted by industry and some was conducted by the National Institutes of Health. How does this new emphasis on comparative effectiveness or patient-centered outcomes research change the paradigm? Dan, would you like to reflect on that?
Well, I think, as Dr. Anthal mentioned in her talk, one of the main pieces is that there's a focus on real-world settings. And you're trying to get data that's helping to frame decisions that clinicians are actually making at the point of care. So rather than using drug A versus drug B or drug A versus placebo, when no one's going to be providing placebo, you get drug A or treatment strategy A versus drug B that would be a realistic alternative for a clinician to use, or a treatment strategy that would also be a realistic alternative. The second major thing that comparative effectiveness research adds is, again, it's in patient populations that are intentionally intended to be more broad and to capture what clinicians are actually dealing with. So traditional clinical trials have focused on a narrow, when they try and define efficacy, they focus on a narrow patient population, restricting very often the patients that clinicians in the office are actually trying to treat. So using that real world setting is really one of the key components.
Deb.
Yeah, and to even go beyond real world setting, what comparative effectiveness also does is it also includes patient-reported outcomes. So not just these more medical measures that we use of effectiveness, but how does that translate then into patients' quality of life and other factors that affect, from their point of view. I don't think any of us address those in our studies, but that's a really powerful piece, I think, of comparative effectiveness research.
Although all of us have done studies of that
Yes,
sort, and,
right.
and that's an area of particular research expertise at CCOR. Claudine, would you like to talk a little bit about the importance of these patient-centered outcomes measures and cost effectiveness as part of the portfolio of research in comparative effectiveness?
Yeah, I think cost effectiveness is really key. More importantly now that we talk a lot about value. Value being effectiveness over cost and the best effectiveness over the lowest cost. And I think that's what we try to achieve, in all clinical medicine. So, it seems that more and more comparative effectiveness includes cost effectiveness, and I don't think we should be afraid of cost effectiveness, that some people are. And that's something that we need to understand better and to analyze for each treatment that we are doing or each intervention that we are doing.
So that's very, very well said. Well, we've heard about a lot of different kinds of studies, and I want to return to the theme again of observational versus randomized trials. What are the places of each of these types of research? Who wants to start off? Dan.
Sure. I think the beauty of observational analyses is that you can use large patient populations that you couldn't otherwise access. So you can use it for large data sets that are collected largely for administrative purposes or for some other purpose, increasingly for a registry, which is an intentional purpose to gather data to do comparative effectiveness research. But regardless of the data source, you can use large patient populations that you wouldn't otherwise have access to. And the expense of doing a randomized clinical trial really is prohibitive to answer the numbers of questions that we have. Now again, we've talked a lot about the limitations of those observational designs, so their results need to be interpreted with caution and with the sensitivity analyses that we talked about before. But clearly there's a role to quickly and retrospectively assess a population-based question using large data sources.
But is it fair to say that the randomized clinical trial is still the gold standard for research?
In most cases, I would say yes.
So when you can, randomize. But there are times when it's just not practical, and then there are other things to do. But we always have to remember all of the caveats and all the difficulties. And all of the statistical approaches in the world can't account for things that you don't measure. And because you can never be sure whether you've measured everything there is or measured it well enough, you're always left with a certain degree of uncertainty in observational studies. Now that can be quantified with sensitivity analysis as well. So at least one of the things we want to do in observational studies is at least look at what it would take for some unmeasured confounder to actually explain our results. Now the other thing you see in comparative effectiveness research is the use of different kinds of databases. And very often we use both administrative databases and we use clinical registries. What are their various places? Deb, how do we integrate these two kinds of data sources?
Yeah, and that's a great question. Certainly in the field of maternal-child health, there's many different sources. We have National Center for Health Statistics, who has vital statistics, which is, kind of one type of data which has, some strengths and some weaknesses. Administrative data, typically billing data, and things as such have great reach across systems, but usually don't have as well-defined medical diagnoses. And then we also have clinical electronic records that we can use. And I think that what we've been doing at this institution is trying to bring them together in a blend and pull the strengths of some and the strengths of others in to make a coherent data set. But I think that really having a very deep understanding of the strength of each element of these is really critical in order to effectively utilize them.
Well, we're always saying that clinical registries are better than administrative databases. What do administrative databases have that clinical registries don't have? What can they add to the mix?
Well, I think
real life data. I mean, that's really the administrative database reflects the treatment of the patients, whereas registry is something which is collective, which is prospectively collected for most of the time for a study. So cannot be as real life data as registry, however, as administrative database. However, I mean, the validation of the outcomes, validation of the clinical attributes of the patients in administrative database is very difficult and is questionable. Dan, you want to?
Well, I was going to say, with registries, like you said, they're often gathered for a select reason or from
Right.
a select population. So administrative data has, both the blessing and curse of being broad and capturing lots of patients, across. So you can sort of massage your definitions potentially a little bit in the administrative data to sort of understand the nuances of your patient population. Whereas, the patients in a registry may be in that registry, they've been selected, maybe a highly selected patient population that's there. So I think the administrative data sets, again, they have their limitations, but there's a breadth to them and and a level of detail about entire clinical utilization, potentially, or pharmacy data that's there that may round out what you may have in a limited registry that was collected for potentially a narrow purpose.
Okay, but there are some registries that are collected with much broader information. An example of that is the Society of Thoracic Surgeons database. Now, Hisham, I suspect you know something about that database. Can you tell us a little bit about the STS database?
The STS database is a North American registry for all cases that have been operated on in cardiac or essentially cardiac or cardiovascular surgical procedures. And it may seem like an out of focus, but it's actually quite a large database, and it has a huge number of parameters and details that are included in each procedure with both administrative and clinical patient-specific data.
Right. So there are very large databases that are like registries, but are broad, like administrative data sets. The SDS is an example of that. We also have the American College of Cardiology databases and the American Heart Association databases, the Get With The Guidelines program. We have a whole series of these databases that we at Christiana are involved in. In addition, we do research with these databases. One of our most important studies here at Christiana is the ASSERT study, which is the American College of Cardiology, Society of Thoracic Surgeons collaboration on comparative effectiveness of revascularization strategies, ASSERT. In the ASSERT, we are linking the SDS CABBAGE database and the American College of Cardiology PCI database, percutaneous coronary intervention database. We're linking both of these databases to an administrative database. The Center for Medicare and Medicaid Services 100% denominator file. With these databases, we'll be able to look broadly at PCI and coronary surgery, two different revascularization strategies, then look at them long-term with data from the administrative database, but also be able to gather sufficient data to perform a cost-effectiveness analysis. This very detailed, very complex analysis is one of our biggest research programs ongoing presently at Christiana and the Center for Outcomes Research. I want to discuss one more topic of important national interest in the field of comparative effectiveness, and that is some of the things that we're doing nationally in this regard. As part of healthcare reform, there was the creation of a new institute called the Patient-Centered Outcomes Research Institute, or PCORI. Now, Dan, maybe you can tell us a little bit about PCORI and what this is all about and how that's going to help us look at healthcare and help us make better choices.
Sure. Well, PCORI, again, as part of the Affordable Care Act, established a body which for the first time will actually set a research agenda that's focused on patient-centered outcomes research. And of course, right now, in the midst of some of the financial struggles, the future of PCORI is somewhat in jeopardy at times. But the focus of PCORI, I think, is something that we all agree with and stand behind, in the sense that it's going to bring policymakers and decision makers and stakeholders from throughout, basically stakeholders from every division or area, into a place where they can actually synthesize and prioritize comparative effectiveness work. And that means defining the agenda moving forward, working with clinicians and policymakers to identify the key issues that will sort of drive care moving forward, and also have a large focus on disseminating those results, as we talked about at the beginning. And then again, the real focus, even with the name change to the Patient-Centered Outcomes Research Institute, really is driving us towards understanding what works for which patients at which time and in what setting. And that's really the information that we as clinicians really need when we're treating patients. It's not one size fits all in medicine, and we're all aware of that. And PCORI as a fundamental mission is going to sort of drive us to understand how those issues work at the bedside. And I think we all as a group are quite excited about the potential and the direction of that institution.
Now, we have a lot of federal institutions in the mix here that are involved in things that are related to comparative effectiveness. We have the FDA and their registration trials. We have the NIH and more efficacy-focused trials. We have ARC, which is focused on more on implementation, and we have CMS, which is focused on the role of the payer and understanding how we make better choices in society. And then we have PCORI. How can all of these various institutions work together?
I think that's really the challenge, and I think that's what PCORI potentially offers, is a synthesizing body through which, again, the prioritization of the questions to be asked and the research to be funded can actually be directed in a systematic way to address the issues that we think are most important. But clearly there's a merging of sort of basic biomedical science infrastructure with patient-centered outcomes research and sort of heavy-weighted T3 translational research that is happening sort of as we're moving through this process together. And I think, again, the merging of those two really is an exciting time to be in this field and to be thinking about these issues and questions.
Now, you brought up another whole area, and that is translational research. And you mentioned T3 translational research. So I'm not going to let you get away with that. I'm going to ask you to define your terms. And maybe we can reflect as sort of our final area of discussion how comparative effectiveness relates to translational research. So what's T1, T2, and T3 translational research?
Well, generally, T1 research relates to traditional sort of bench science, and T2 work takes that science from the bench to the bedside, and the T3 component generally thinks about the bedside to actually the larger community. And this is sort of the translational pathway that's been set out by the NIH. And comparative effectiveness research essentially works, as I understand it, largely in a T2 and T3 spectrum to understand the dissemination of basic biomedical knowledge to the clinical application. And again, with the T3 focus, that dissemination to the places where patients are treated.
Now, Deb, you've been involved in translational research, and you've thought about this a lot. How do you see translational research and comparative effectiveness working together?
That's a great question. I think that translational research is very broadly encompassing, and I think comparative effectiveness is a piece of translational research that I think we feel is very fundamental to effectively translating what we know from our clinical studies into practice. But what comparative effectiveness does is it provides a way to answer questions that earlier research hasn't done. We talked about, choosing between therapies that had never been tested head-to-head, taking into account patient-reported outcomes. So I think it just makes much more rich the translational research agenda.
Yeah, so that's very well said. These things are not separate fields, nor are they in opposition to each other. But really, comparative effectiveness is part of the spectrum of things that you do in translational research to help you make good choices, and also to help implement those choices in the community. Now we're going to wrap up shortly, but what I want to do is go around the panel and give each of you sort of a last word on your thoughts about comparative effectiveness research. And we'll start with Dan.
Well, again, I think going back to where you started with the Institute of Medicine priorities on health delivery systems measurement and implementation research. And I think when you see 50 of the top 100 priorities of the Institute of Medicine focusing on delivery systems, I think that is really the area where we need to be spending our time. Now, that's not to say that we've learned everything we need to know about basic biomedical science, because clearly that needs to go on. But it's a reflection of the fact that we've potentially not paid as much attention to the delivery system aspect of care as we should. And as such, we've seen the dissemination of medical knowledge actually be very hindered in real practice. So again, I think moving forward, the area, again, where a lot of my work is focused and the things that interest me most are how we're going to focus on that delivery system to provide patients what they need and when they need it. And a big part of that, of course, in my opinion, is supporting doctors and understanding how to provide them the information and the tools that they need. So again, I can't overstate how exciting this time is to be in this field.
Claudine.
Just in one word, I think one important thing, as I've already said, is the issue of value and having really the best outcome and being able to measure these outcomes. And I know that at Christiana Care there is a huge effort now to try to emphasize the measurement of outcomes. So measure outcomes, having the best outcomes for the less cost. That's a large part of comparative effectiveness.
Absolutely. Hisham.
I think comparative effectiveness is the best framework to provide the best evidence-based information to support and make it available to as many clinicians as possible to support the best decision-making, which will in turn provide the best outcomes with the most efficient resource utilizations. So I share Claudine's excitement about this framework.
About value.
About value, because.
And I'll round it out and I'll say I think that the focus on patient health status, patient-reported outcomes is really fundamental for us to remember. And I think comparative effectiveness research encompassing that as one of its key outcomes, I think brings it front and center.
Well, thanks, everybody. So I want to say just a few words in closing. What comparative effectiveness research is about patient-centered outcomes research. And that's why PCORI is well named, and that's what we're about at CCOR. We are about patient-centered outcomes research. We're about developing good healthcare systems. We are about looking at patient-reported outcomes, the things they care about most, very often how well they can function in their daily lives, how symptomatic they are. After all, what we want to do very often is relieve suffering. And finally, we have a responsibility to society, to our institutions, and to the population of the United States, to all citizens of the United States, to provide value. And that means we have to make good choices. And comparative effectiveness research is a key approach or set of approaches to allow us to make these good choices. Well, thank you very much for spending time with us from Christiana Care and the Christiana Care Center for Outcomes Research. I hope you've learned a good deal this afternoon about comparative effectiveness research.